Bismillah ar-Rahman ar-Rahim. I'm Dr. Muhammad Alat, Assistant Professor of Radiology, Cairo University. Really, we conducted first 5 sessions today, and I'm sorry that I started to record the session starting from the second case. So the first case, I will show it to you by myself. I will present this case by myself. This is non-contact scan of the brain for an adult patient. We have here right paracellular space occupying lesion, and this lesion shows marginal calcifications, marginal dense calcifications, and this lesion is very close to the anterior clinoid process. Also, the lesion is seen indenting the hippocampus posteriorly. The lesion also is very close to the M1 segment of the right middle cerebral artery. The lesion is intimately related to the cavernous portion of the right internal carotid artery medial. So, in conclusion, our 2 top differential diagnoses in this case: first, meningioma; second, giant saccular aneurysm arising from the internal carotid artery. If we have any aneurysm, it may be arising from the bifurcation of the artery. If we have this artery, and this is the bifurcation, this one is called bifurcational aneurysm. Sometimes the aneurysm is coming sideways. This one is less common. The more common is the bifurcational aneurysm. So if this one is giant saccular aneurysm, it will be arising from the internal carotid artery, and this one is much less common. If it is arising from the bifurcation of the supraclinoid portion of the internal carotid artery, the aneurysm will be here, and the center of the aneurysm will be at this point. But I think the mass lesion is along the right side of the internal carotid artery. So our differential diagnosis will be a calcified meningioma rather than giant saccular aneurysm. So the next step for this case is to see the bone window. The bone window is very helpful. We should search for any sclerotic reaction along the bone. It will be with meningioma. Let's check the bone window. We don't have any significant sclerotic reaction along the nearby bones. So let's go. We did MRI study for the same patient, and as you see here, we have a very clear REM, hyper-intense REM of CSF signal. This is called CSF cleft sign, indicating that we are dealing with an extra-axial space occupying lesion, and the lesion is seen surrounded by a REM of hypo-intense signal, reflecting calcifications. Also, the lesion is seen intimately related to the patent M1 segment of the right middle cerebral artery, very close to the cavernous portion of the right internal carotid artery. The lesion space iso-intense, rather homogeneous signal intensity in T2 with image. Let's go to the post-contrast setting. The lesion shows homogeneous contrast enhancement and partially encasing the internal carotid artery. So all of these criteria are matching with a meningioma. And this meningioma is very characteristic for anterior clinoid process meningioma. If you can see here, the sagittal plane, this is the anterior clinoid process, and this is the meningioma. It's dural based against the anterior clinoid process and uplifting the right middle cerebral artery. Also, the lesion is seen uplifting the inferior frontal gyrus here. This is the lesion. The lesion extends into the middle cave at this area. Also, the lesion is seen partially encroaching upon the supracellular cistern with no significant compression upon the optic chiasm. this is optic asthma. So this is the anterior clinoid process, and this is the mass lesion. It's very specific to be anterior clinoid process meningioma. Let's go to the second case. Will be MRI assessment. Do you agree?
Yes, sir. MRI.
Okay.
This is T2 FET set, a coronal view with, I think, without contrast of the same patient. The lesion is showing internal septations. It is T2 hyperintense and
Yes.
is showing multiple, few other fluid levels as well. I cannot appreciate that there is any breach on this particular image.
Can we continue, please, Dr. Marie?
Yes, sir. So there is a T2 hyperintense lesion with internal fluid level, well-defined margins, and within it, a lesion is causing a scalping of the bone. The overlying soft tissue swelling, the overlying soft tissue is quite splayed, and the tendons are also quite stretched by the lesion. In the posterior to it, there are tarsal bones, and there are some reactionary internal hyperintense changes within the tarsal bones. Remainder of the joints and muscles, soft tissue, bones, calcaneum, they are not showing any similar lesion. So I believe this is a single lesion. Underlying muscles are also showing some increased inflammatory changes in the sole of the foot. So next, I would like to, in my routine practice, I would see it on the rest of the imaging to see its relation, and if I don't. I would also like to have a post contrast to see any soft tissue component. Although I can appreciate that there is no one at this level.
Do you have any explanation for this mottled foci of edema signal?
Multiple foci. I can appreciate that there are multiple foci within the talus, calcaneum, and multiple navicular bones. They could be patient. Could be some known case of any disease. These could be infarcts.
Okay.
Or it could be bone cyst.
Yeah.
If the patient has any known association like congenital disease, it could be due to neurofibromatosis or tuberous sclerosis.
Yes. Okay. So let's see together the post-contrast series.
In the post-contrast T1 FET set, PD FET set imaging, I can appreciate that it is a rim enhancement of the mass, and posterior to it, there is some soft tissue enhancement as well. There's although no soft tissue component. Actually the hyperintensities within the bone are showing thin rim enhancement.
Okay. Right. Let's conclude this case. I think I totally agree with. Yeah. What do you do? What do you say?
So can this be bone infarcts?
Bone infarcts, but I think bone infarcts, it will not be expansile like this one. It's
no, sir,
expansile. It's bubbly lesion.
Sir, I think if we
yes, let's start to conclude. So we have a large markedly expansile or bubbly lytic lesion with some internal septations, as we saw in the X-ray. And I think if we think for what are the expansile lytic lesion, we have figno, Mashik. Okay, you are right.
Yes, sir.
Okay. Is it fibrous dysplasia? I think the location is far away. Is it infodroma? Maybe. I agree with you. Maybe. Is it giant cell tumor? I think it's difficult to be giant cell tumor, not typical location. Is it non-ossifying fibroma? It's not non-ossifying fibroma. Maybe osteoblastoma, not the location. Metastasis, it's not aggressive. What do you think? Aneurysm bone cyst, maybe.
Maybe there were some fluid levels, but less likely.
Maybe, yeah. I agree with you because fluid level is much less because I think we have here one or two fluid levels. So aneurysm bone cyst and enchondroma in our differential. Is it brown tumor or hyperparaceletism? I think no. Is it infection? No. Is it chondrosarcoma? No. So enchondroma and aneurysm bone cyst, and I think you said also spina ventosa. One of our differential diagnoses. I think also we have here this mottled foci of high signal intensity at the rest of the bones can be explained by zodiac atrophy or something what we call the reflex sympathetic dystrophy. Because this patient is not using his foot as we use it in our routine practice. He uses this one much less. So this one can be physiologically compensated by this mottled edema signal or foci at the rest of the bones. This one can be explained by reflex sympathetic dystrophy or zodiac atrophy. Okay. So thank you so much.
Thank you so much, sir. Very good case. Thank you, sir.
Thank you. Complaining of lower back pain, and clinician is suspecting sacroiliitis.
Sorry, so what is the clinician?
Sacroiliitis.
Okay.
Sacroiliac joint abnormality. Yeah.
Okay.
What's your opinion?
I'm looking at the radiograph pelvis of a skeletally mature patient.
Yes.
Firstly, I think that right SI joint space is slightly widened as compared to the left. However, and I could appreciate a tiny erosion at right as well. The left SI joint seems fine.
Yes.
And the rest of the bones, I'm looking, I could not appreciate any lesion. However, I can't see the right femur very well.
Okay.
The sacral arches and the sacral foramen are also intact, and the pubic symphysis is also normal.
Okay.
There is maybe rectal gas shadows noted. So I am thinking of unilateral sacroiliitis, and I would like to correlate it with MR and patient's history of any infection or IV drug abuse or HIV.
Okay. Okay. Let's go to our scenario because the referring physician requested to do CT scan of the pelvis. Okay. Let's see the CT scan.
Okay. So I could see CT scan, bone window.
Yeah.
And I could appreciate subtle. I could appreciate there is a ill-defined lesion noted in the right iliac bone.
Yes.
Ill-defined lesion involving the. So can you scroll up and down for me, please?
Yeah, you can scroll if you want, please.
Yeah, okay, I can try.
Yeah.
So I have requested remote control.
Yes. Okay, go on.
No, sir, I am unable to scroll. Please scroll it for me.
Okay, no problem. Okay.
I'm giving it back. Okay, so there's a mixed lytic sclerotic lesion involving the right acetabulum with the cortical break and mild surrounding periosteal reaction. I could not see any obvious soft tissue component. Now, considering the patient is a little bit old age, I'm thinking of some aggressive pathology here. Sir, can you show me the prostate?
Okay. Let's go to the soft tissue.
Yeah, the same lesion is appreciated. However, the prostate is normal, and I could appreciate right-sided fat-containing inguinal hernia and calcific changes at pubic symphysis, likely just inflammation. So the main lesion is in the right acetabulum, and it seems to me that it is an aggressive lesion. So
Aggressive lesion, okay, perfect.
yeah.
Yeah, I agree with you.
So considering the age of the patient, I'm thinking of myeloma or METs and less likely lymphoma.
Yes.
However,
Okay.
I could not see any obviously enlarged lymph nodes in the given soft tissue window.
Yeah.
I'm looking. There are large degenerative changes in osteophytes. So can you show me the sigmoid once more? Sigmoid colon and
The
rectum.
sigmoid. Okay.
Yeah, the rectum. Uh, no, it's mostly collapsed, so I couldn't evaluate it properly. However, I think it's thickened, but it's collapsed. So I'm not sure
Okay.
that.
Okay. Okay. Really, you did very well. Really, this case, when I saw this case at the first time, I saw this CT scan of the pelvis, and I agree with you that we have an aggressive lytic lesion. Let's go to the bone window again. Yes, as you said here, we have an aggressive, ill-defined, permeative lytic lesion, because this one is an aggressive lesion. Permeative is a very specific term for this lytic lesion. And we have also cortical breaching. We don't have sizable extraosseous soft tissue component, but really I agree with you that the first logic thinking is metastasis. The second is multiple myeloma. Really agree with you. Maybe lymphoma, maybe, and other aggressive lesions, fibrosarcoma, and all of these. But metastasis, one of the most common cause for this case. And I agree with you that you started to search for the primary osseous lesion. Sorry, you started to search for the primary tumor. Prostate almost normal. But I think we have here something like mural thickening at the rectosigmoid junction.
Yes, sir,
At
I
this
agree.
area. Do you agree with me?
Yes,
This one
sir.
is, I'm not happy by this area. It's not, I'm not sure, but really, I'm not happy by this area. I think there may be like mural thickening and possible
Yeah.
extra exophatic soft tissue component at this site. So even we have some mesorectal lymph nodes. So I think in my routine practice, as you said, that we will search
MRI.
for any lymph node for any primary tumor. We recommended to do for this case CT abdomen and pelvis and chest with oral and IV contrast. Let's see what will we find. Okay.
Sir, I'm looking at the CT scan images. I could appreciate multiple lung nodules and mild bilateral pleural effusions.
Just a minute, I am sorry.
Okay.
Okay. Yeah,
Sir,
we have multiple pulmonary nodules. Okay.
I could say multiple pulmonary nodules. I could appreciate bony mets involving the ribs
Yes, you are right at this area.
with destruction
At
and
this
soft
rib.
tissue component.
Yes, agree.
Bilateral pleural effusion, multiple liver lesions
Okay.
in both the lobes. I could appreciate bilateral renal cyst. There is contrast to specified large bowel loop.
Okay.
And there's eccentric thickening involving the rectosigmoid junction.
Agree.
So I think the MRI should be done to see if there is any mass over here. or otherwise we can do a sigmoidoscopy and biopsy.
Yes, you are right. So
as it is
lower
suspected.
GI endoscopic biopsy is very important to judge or confirm this colonic lesion. So we have non-uniform endophytic mural thickening at the rectosigmoid junction, and we have also something like exophytic component here at this area. So the logic thinking here is that we have colonic adenocarcinoma with osseous deposits, hepatic deposits, pulmonary deposits, and we have also right side, or I think bilateral mild pleural effusion.
Yes.
So this case, let's review the X-ray, maybe retrograde, maybe you find something.
Okay. Yeah. I could appreciate
I
and
think
find
yeah.
the sensory in the right acetabulum.
I think it's difficult, and really it was missed from us as well, really, and time of reporting. But if we go by our checklist at any X-ray pelvis, you should check 4 rings: the internal ring, the external ring. The external ring, if you check the external ring, you will find here like cortical breaching, and you will find faint osteolytic lesion at the right acetabulum and adjacent right iliac bone. So you should check the internal ring, you should check the external ring, and also you should check the obturator rings, the cortex of the obturator rings. Also, you should check this ring along the inferior aspect of the femoral neck. Please put this one in your checklist. The cortex here is disrupted at this area. Okay, let's go to our next case. Sorry.
Yes.
Okay.
I hope so.
This is an adult patient complaining of very strange, really very strange complaint. He is complaining of right iliac fossa pain and being localized in the right inguinal region.
Okay.
Can you please start to scroll the case if you want?
Okay. Just 1 second. I will ask it for. I'm asking.
Yes. Okay, go on.
Okay. Okay. I've been provided with axial cut CT chest for an adult patient complaining of right inguinal pain. This CT is with non-contrast. Just I will scrolling down and then I will comment. The pain is in, sorry, right or left inguinal?
Right side, right side.
Right side inguinal, okay. Just I will go to the end and then, sorry. Okay, I couldn't see any evidence of hernia. Just also I couldn't see abnormality within the intestine. No evidence of intestinal obstruction. Just there is fecal. Okay, only there is a fecal loaded in the cecal region.
Okay, agree.
Just.
Can you go by your own checklist and ignore the history? Ignore the complaint of the patient. Really.
Okay.
Because it's misleading. I'm sorry.
Okay. I will go from up to downward. Both the lung fields, I couldn't see abnormalities.
Yeah,
I couldn't see evidence of bilateral effusion.
Okay. Go to the liver.
Liver appearing normal.
Liver and gallbladder is normal.
Gallbladder also appearing normal. Pancreas appearing normal. Spleen appearing normal. Both kidneys also appearing normal.
Yes.
Aorta appearing normal and IVC.
Yes.
Just I couldn't see evidence of hernia in the abdominal wall.
Yeah.
And this is the aorta and both anterior. Yeah, I feel that there is abnormality in the mesentery surrounded the bifurcation of the aorta.
Yes.
So much clear. This area is not clear for me yet.
Okay. So in your checklist, you should check for any other abnormalities in the mesentery, and you found soft tissue density, rounded soft tissue density along the inferior mesenteric vessels. You are right.
Yes.
Okay.
Yes, here, this
just
region.
Inferior to the aortic bifurcation. Agree?
Yeah.
Yes.
Just it's disappear. It's only for this section.
Yes.
For my routine practice, for sure, I would go for contrast, the CT, to check what
the abdomen and the pelvis is gone. Okay, agree. So this is abnormality that you described. Okay.
Yeah.
And this is CT scan with oral contrast.
But this is with oral.
Yeah.
Okay. Okay. Let me check if I can scroll. Yes. This area. Just 1 second. Yeah. Sorry, sir. It's jumping.
No problem.
Okay. This region.
Yes.
But this is with oral contrast only. There is no intravenous contrast.
Okay. I will give you the intravenous. Okay, no problem. Just a minute. I will give you the axial. I think I don't know really where is the axial, but but I think the coronal that we reviewed now, it's very obvious to see the abnormality.
Yeah, just I want to know the relations for this abnormality. Does not have any relation with the intestine, as I can see.
It doesn't have any relation to the intestine.
Yes, so it's maybe from the wall of the aorta or from the mesentery itself. So it could be carcinoid tumor.
Okay, it's very obvious to see the abnormality.
Yeah, just I want to know the relations for this abnormality. Does not have any relation with the intestine, as I can see.
It doesn't have any relation to the intestine.
Yes, so it's maybe from the wall of the aorta or from the mesentery itself. So it could be carcinoid tumor.
Okay.
So I want to check if it has any contrast enhancement to know about.
Let me. I'm sorry that really I prepared the IV contrast study, but really I didn't find here. But it's obvious now to have. This is the aorta.
Yes, this is a wall of the aorta. Maybe this is a tumor coming from the wall of the aorta, like leiomyosarcoma or angiosarcoma.
I think I don't know who started to draw by himself. Really. Type anyway. This is aorta, okay, and this is the inferior mesenteric vessels. It's coming from the aorta. This is the inferior mesenteric vessels, and this is lymph node along the inferior mesenteric vessels. This is the larger one, and this is the smaller one. So we have multiple inferior mesenteric lymphadenopathy. So once we have something like this, directly you should contact or you should check
check.
The colon.
The colon, yes.
Yeah, we have
Okay.
apple
There
core
is a
lesion.
mural thickening of the sigmoid
Yes.
colon, I think.
Yes. Yes.
Okay.
So this one is suspicious
this
for.
is a colon cancer
Yes,
with
you are right.
mesenteric lymph node. Okay.
Yes, you are right. You are right. I'm sorry that I didn't show you the contrast enhanced study, the full contrast enhanced study, but I think you got the idea. Okay. Thank you so much.
Sir, could this be any, if something like this, could this be how to differentiate between lymph node and if this is a mass, another mass in the mesentery from the mesentery
Yes.
itself?
Okay. Maybe extraadrenal phagocytoma for something like this, or sympathetic chain tumor or something like this. You are right. But we have two lesions, not one lesions. And also, really, when we started to inject the contrast media, you will see the core of the lesion is necrotic. Really, it's very characteristic. But really, I'm sorry. Sorry. But we have also primary lesion. We have something very suspicious.
Yes.
Should explain our case. Thank you so much.
Yeah. Thank you.
Okay. Let's go to Dr. Khalida.
Okay.
Dr. Khalida? Yeah.
Yeah.
How are you?
It's fine. Alhamdulillah.
How are you? Let's go to our next case. Just a minute. Okay. Are you ready?
Okay. Okay. Thank you.
Go on. Welcome.
Okay. So I've been presented with X-ray frontal projection of lower tibia and ankle joint, where I can of a skeletally immature patient. Here I can see that there is a well-defined lucent lesion with internal septation seen involving the distal metadiaphyseal region of the left tibia. It is showing narrow zone of transition, and there is no periosteal reaction. In my routine practice, I will check the orthogonal view for the presence of any associated fracture line or pathological fracture or soft tissue component. Here I can see that there is a lucent area which is projecting over the superior aspect of the lesion. So I'm suspecting a pathological fracture. Yeah.
Yes, you are right. Very, very nice. Thank you. Okay. You are doing well. Yeah, go on.
So I'm suspecting pathological fracture. So for this lesion, the differentials are this could be aneurysmal bone cyst, or this could be an enchondroma, but I cannot find any chondromatoid lesion here. So on a lateral view, I can see there is a pathological fracture which is extending through the lesion. So I'll immediately convey the finding to the referring physician. And for ortho management of this patient, as patient has developed pathological fracture. So the other differential could be a cortical defect, fibrous cortical defect, but they are usually present in the anterior tibial region, and they are cortical lesions which are present mostly in the anterior tibial, but they can be present atypically. Yeah.
Okay. So I think in conclusion that, as you said, we have frontal and lateral plain radiographic examination of the left ankle and the lower leg, and we have an eccentric, mildly expansile lytic lesion, and this lesion shows, as we said before, we should describe the lesion from inside to outside. The lesion is lytic, and it shows multiple internal septations, and I think it shows also some endosteal scalloping, and the lesion is surrounded by very sharp sclerotic margin with narrow zone of transition. We don't have any extra-osseous soft tissue component, but we have pathological fracture very clear in this case, and you did very well. Really, you picked up the fracture at the AP view because you are searching for any complications. As we said, that our differential for expansile lytic lesions phygnomash, as we said, and I think the most common cause or diagnosis for this case is non-ossifying fibroma or fibrous cortical defect. This is most common because it's surrounded by sclerotic margin, non-aggressive lesion. Aneurysmal cyst maybe, but I think it's for a little bit away. But if we need to confirm the diagnosis, I think, what do you think? If we want to confirm or differentiate between those lytic lesions, is there any next step or something you want to add?
Yeah, we can go for MR of the same region to confirm.
Okay, let's go to the MRI.
So on MRT2 fat set image, I can see that there is a well-defined low-intensity rim, which is representing the sclerotic area, which we already saw on X-ray, and there are heterogeneous signal, more intermediate signal, and few area of intense high T2 signal within it. So there is no soft tissue component, and so this confirms the finding of a non-aggressive lesion like non-ossifying fibroma in this case.
Okay, totally agree. Yes. Yes, as you said, and because of the time, I'm sorry. This case, as you said perfectly, this case, the first diagnosis is non-ossifying fibroma. We don't have any fluid levels, so aneurysmal cyst is not logic in this case. We don't have any extraosseous soft tissue component, but we have soft tissue edema, and this one can be explained by the pathological fracture across the region. Really, we diagnose this case as non-ossifying fibroma, and the case was managed conservatively. Yes, managed conservatively, and after 1 year, I think now, as you see here, the non-ossifying fibroma is partially healed and partially indistinct, and alhamdulillah, it was managed perfectly. Okay, do you want to add something?
No, thank you.
Thank you so much. Thank you.
Available, I will do it.
Okay, okay, no problem. Okay, right. We have here, as you see here, can you comment on this case, please?
So this is chest X-ray frontal projection of an adult skeletally mature individual. I can appreciate that there are bilateral volume loss.
Okay.
And I can also appreciate that there are multiple cystic areas of prominent interstitial marking with the prominent apico-basal gradient seen. Bilateral CP angles are showing some hazy infiltrates, although I cannot appreciate any pleural effusion. The cardiac shadow is within normal range. The cardiac silhouette is showing blurry margins, which are most likely due to the prominent interstitial changes. I am looking for any rib erosions.
Okay.
Which are not present, any underlying calcification, bilateral hyla, pulmonary arteries, aortic knuckle are normally visualized. There are some degenerative bony changes in the left shoulder region as well. So I would, in this case, I'm also appreciating a faint calcific area within the left adrenal region, or it could be some old calcified healed granuloma. There is a calcification seen in the just inferior to the left diaphragmatic region. So based on these findings, if the patient is young, it could be some cystic fibrosis. If the patient is known case of any long-standing lung disease, it can be of the patient. Third differential is UIP.
Okay, perfect. Really, you did very well. And just I want to add something very important. Did you check the bones?
Sir,
all the bones?
About the bones are showing some degenerative changes in the left bilateral humeral regions, and
left what?
There is some irregularities around the margin. There are some end plate depressions and bony degenerative changes. Also, there is in the subcarinal region, posteriorly, there are some erosions along the lateral margins of the vertebral body.
No, ignore this one. Can you check with me, please, the ribs?
Ribs. Sir, there is are these changes within the bone, these expansile changes?
Okay.
It could be that the ribs are showing expansile changes.
Okay. Yeah. What's your recommendation? What's the next step?
Sir, CT chest with contrast.
CT chest? Okay. Okay.
With bone window as well.
Let's go to the CT chest. Okay.
Sir, this is, sir, should I start describing?
Yeah, just a minute. I will make it much better for you. I'm sorry. Okay. Okay, go on. Can you, if you want to scroll by yourself?
Sir, it's okay. If you can do it, please. This is HRCT image lung window of the same patient. My findings of interstitial changes are demonstrated. They have a epicobasal gradient. There is bilateral pleural effusion. There are there's peripheral honeycombing as well. There is some fissure, some fluid tracking along the fissures as well. And next, I would like to see the soft tissue window. There is also some element of pericardial effusion.
Pericardial effusion. Let's see the mediastinal window to check this point.
Yeah, bone window.
Okay. So you have, as you said here, we have interstitial reticular infiltrates, more pronounced at the subpleural region, and it's associated with honeycombing areas, cystic honeycombing areas, and parenchymal distortion. And I think also the interstitial thickening is more pronounced at the basal lung segments. Okay.
Okay.
Do you have anything else you want to
I
add?
would like to see bone window as well. There is in the esophageal region.
Okay, no problem. Let's see the mediastinal window. I think we don't have significant pericardial effusion apart from this area. Yeah, but I think we don't have sizable pericardial effusion. We have, for a little bit, minimal bilateral pleural effusion. Okay. Is there anything you want to add in this case?
Sir, I'm looking for the esophagus. It is not patulous and not dilated. I'm looking for any lymphadenopathy.
Perfect. Perfect.
I'm looking for lymphadenopathy.
The esophagus is not dilated. Is that correct?
Yes, it is not dilated.
Okay, that's good.
Sir,
okay.
There are both.
Okay. Let's conclude what we saw in this case. Really, this is non-contrasty scan of the chest for an adult patient. As you said, we have reticular infiltrates, network of reticular infiltrates, more pronounced at the subpleural region and basal lung segments. And we don't have any subpleural sparing, so the articulations is going or extending to the pleural reflections. This picture is suggestive of usual interstitial pneumonitis And once we have usual interstitial pneumonitis, you should search for many points. First, you should check if there is any pleural calcifications to rule out possibility of asbestosis. We don't have any pleural calcifications. Second, we should check the esophageal dilatation. We don't have any esophageal dilatation. If we have esophageal dilatation, scleroderma is very common. Also, you should check the mediastinal window if there is any increase of the liver density, because it can reflect drug-induced usual interstitial pneumonitis. We don't have any abnormal density in the liver. So the main two causes for usual interstitial pneumonitis is collagen vascular disease and drug-induced usual interstitial pneumonitis. But if we didn't find a clear cause, it's called idiopathic pulmonary fibrosis. So I want to add something very important here, because as much as you can, you should not be satisfied by the case. Look for this one. You will find here pulmonary nodules, and these pulmonary nodules widely scattered, randomly scattered. One of them is pleural based, subpleural, and these nodules are variable in size, not similar in size. Look for this one. You will find multiple variable sized pulmonary nodules randomly distributed. And also, don't forget to check the bone, please. The bone and vessels. If you check the bone, or you asked me to check the bone, you will find here
lytic erosion. There's erosion.
Yeah, we have here an aggressive osteolytic lesion at this rib. Maybe something like metastatic lesion. Once we have something like this, you should search for any primary lesion. We have here subpleural soft tissue lesion at the apical segment of the right upper lung loop. I don't know, is it primary or not, but you should comment and you should put it in your report. Maybe this is primary adenocarcinoma, peripheral adenocarcinoma, maybe pulmonary nodules as well, maybe area of consolidative changes. I don't know really, because this one is very small and non-specific, but needs clear follow-up. But in conclusion, that we have here double pathology. We have usual interstitial pneumonitis, and also we have pulmonary nodules, maybe metastatic, and also there is osteolytic aggressive lesion involving the posterior aspect of the left seventh rib. You should search for any primary lesion, and metastatic workup is recommended for this case. I think that's enough for this case. Let's move to our last case, please.
دكتور بعد اذن حضرتك ممكن نرجع نشوف الاكس راي بتاع الحاله تاني عشان نشوف
نرجع صحيح
الريب ليجن ده ما خدناش بالنا منه.
You're right. This, yeah, you're right.
What?
You are right. The X-ray, I think if you review the X-ray again, it's very clear. If you go rib by rib, you will find this area. The cortex of this rib is ill-defined, not like the rib above. Look for the rib above. The cortex is very defined. Look here, the rib is ill-defined. The cortex of the rib is ill-defined as compared to the contralateral side. I think, I know that the case is challenging, but I hope you can find these abnormalities. If you are searching for the abnormalities, it will be easy for you as much as you can. Okay?
Okay, doctor.
Let's move to our next case. Okay. This case is complaining of attack of vertigo. Can you scroll? Yes. Yeah.
Yes, sir. I can.
Yes, go on.
Sir,
This patient
axial
really,
CT
I received this patient complaining of an attack of vertigo on my emergency setting. Yeah, go on.
Sir, I can. It's not scrolling.
You can scroll. Okay.
I'm trying, but it's not. If you, yeah, okay. Sir, axial slices CT scan of an adult. He's having attacks or vertigo. Just jumping a bit. Sir, can you scroll for me because it is not happening? Sorry.
No problem.
So a few specks of calcifications noted in the basal ganglia.
Okay.
The deep gray matter and the periventricular gray matter, white matter appears normal. History of fossa structures are okay.
That's good.
I'm not able to, no appreciable subacute or acute hemorrhage noted. The sulci with the vertex are symmetrical.
You are right.
Sir, I would like to have a bone window to see the inner ear, the mastoid part.
Okay. Just a minute. I don't know. Is the one window? Yes, this is the bound.
Sir, bilateral mastoids appear normally aerated. Middle ear cavities are also normally aerated.
Very important this point. Okay.
Sir, the bones appear grossly intact.
Yes.
The mild sinusitis.
Yes.
Not very much specific for anything.
Okay. Let's return back to the soft tissue window.
Yes,
please.
Sir, sure.
And okay.
Yes, sir. So there is mild asymmetry in the oropharynx.
Just a minute. I'm sorry.
Yes, sir. You can scroll with me.
Okay. Let's focus for the posterior fossa.
Sorry, sir. Let's focus on that.
Let's focus on the posterior fossa.
Sir, there is a soft tissue density area in the right CP angle that is extending on into the internal artery canal, porous costicus.
Yes, perfect. Yes.
Yes, sir.
Is this abnormality can explain the patient complaint?
Sir, depending upon that its extension and involvement of the nerve, we can suggest. So
what's your differential diagnosis in this case?
Sir, as I can see mild extension into the porous acousticus. My first more will be a schwannoma rather than a meningioma. But of course, I would like to have an MRI, contrast enhanced studies to rule out further.
Okay.
Sir, again, I can appreciate a soft tissue density alter signal area, eliciting low signal on T2 in the right CP angle, and it is seen extending into the ISC, into the porous acousticus. So I would like to see the post contrast images of the scan.
Okay.
Yes, sir. It is avidly enhancing on the post contrast studies. So my topmost differential is actually schwannoma because of its extension into the IAC, porous acousticus. And the second thing will be meningioma. Second topmost differential will be a meningioma.
How can we differentiate between both of these diagnoses?
Sir, meningiomas, first of all, do not extend into the IAC. Secondly, they have a dural tail and more common in the females. And
Okay. Also, sometimes in large meningioma can extend inside the internal canal, but the standard or the classic teaching findings to differentiate that any extension inside the internal canal is going with acoustic neuroma. Yes, you are right.
Yes.
Okay.
Yes, sir.
So we have here a right side cerebellopontine angle space occupying lesion. This space occupying lesion is ice cream in cone configuration.
Yes, sir. Yes.
Is that correct? This is
Yes,
ice
sir. I
cream
will
cone.
further review all of the cervical spine and the brain to see any
Yes.
associated meningiomas and neuromas to rule out
Yes,
the
you are
second
right.
NF2.
You are right. You are right. This is a good idea. I agree with you. And I think the most challenging point here is to catch or to pick up the abnormality in the CT scan of the brain. And just I would like to invite you all to watch my YouTube channel that I published an emergency CT brain course. And the first session in this course is CT brain checklist. And I think if you go step by step by this checklist, inshallah, you will not miss any significant, at least any significant abnormality during your reporting. I hope you enjoyed our Viva session. Just last comment is that
Yes, thank you.
I forgot to add something very important in one of our cases, expansile lytic lesion and the second metatarsal bone. I think one also of our differential diagnosis is telangiectatic osteosarcoma, and we can differentiate this one from the other possibilities like enchondroma or aneurysm consist by nodular enhancing septi. Also, it can appreciate like some osteoid matrix, but we didn't have really any of these findings. But we should think any expansile lytic lesion, papillary lesion, if you have any suspicious of aneurysm bone cyst or at the extremity like enchondroma, you should think also for telangiectatic osteosarcoma. This is the last point for me. And I hope you enjoyed our Viva session. Really, it was the first Viva session for me. I think, I hope that it is helpful for all of you. And
yes, sir. Thank you so much.
Thank you so much. I hope to make another Viva session, inshallah. And I am happy to receive your feedback.
Doctor, YouTube channel link, please.
My YouTube channel is present. Okay, I will excuse. Okay, I will share it in our WhatsApp group. Also, I will excuse Dr. Nahla to share it in the WhatsApp group. Inshallah, yani I upload or I started to upload some advanced courses and also some basic courses. Also, I will start to upload very simple teaching cases. Hoping to be helpful, inshallah, for all of you. Thank you so much. And if you have any feedback, really, I'm happy to receive any of your feedback. Thank you so much.